when he succeeded Dr. B.T. Beasley, the original Secretary of the Congress, in 1960. He retired as Secretary Director of the Congress in 1986 and passed away at the age of 93 in 2010. Now, it gives me great pleasure to introduce our lecturer for this named lecture this morning, and I'll start by making a bold statement. Tracy Hull is one of the preeminent colorectal surgeons in the world. How can I say that? The world is a big place. For the past several years, I've had the unique privilege to share membership with Tracy in an exclusive international specialty society, which counts among its members surgeons to royalty, queens, heads of state, artists, and titans of industry. Tracy Hull was not only the president of that society, she is universally referred to by its members as its moral compass. I have observed surgeons literally travel across continents to attend that meeting for the sole purpose of gaining some one-on-one time with Tracy to discuss a difficult case or cases. I know this because I am one of those surgeons. After 31 years of dedicated service to the Cleveland Clinic, Tracy retired in August of 2024, and despite that, she remains worthy of the highest compliment one can pay a colleague in this profession. She is a surgeon's surgeon. Why? Because she still sleeps with her phone at her bedside, and because she knows that it's likely to ring with a scrub surgeon deep in the pelvis, the phone being held up to their ear by a circulating nurse, in trouble. In that sense, her impact in terms of patient outcomes and safety hasn't skipped a beat since she laid down the knife a year and a half ago. And her surgeon satisfaction scores are through the roof. When I learned that I would become president of the Southeastern Surgical Congress, one of the first thoughts that literally came to my mind was that I wanted to leverage my relationship with Tracy to share her with the Congress and enrich our proceedings. Uncharacteristically, I made this request almost 2 years in advance. And in the same way she picks up the phone for former students, trainees, and colleagues at all hours of the day and night, she didn't hesitate to respond affirmatively and graciously thank me for the honor. Please join me in welcoming Dr. Tracy Hull to the podium for the 2026 A. Hamblin Letton Lecture, The Miracle of Progress.
Thank you very much for those comments. I hope I can live up to them. I wish my parents were here to hear that. I have really nothing major to disclose, except I'm going to tell you about the history of rectal cancer from my perspective. And it may not be what you're going to read in books, but it's my perspective through my career. And it's appropriate that I'm going to talk about rectal cancer because, as you heard, Dr. Letton was an outside of the box thinker about cancer. And actually, my favorite story reading about him was when Pap tests were first becoming a thing, and most doctors would not do them because they thought that they were going to be a passing fad. He encouraged women to go to their gynecologist and their doctors and say, well, doctor down the street will do it. I'll go down the street. And people didn't want to lose that business. And I thought that was very, very innovative. So I've known Dr. Zervos for a long time, as you can tell. And if anybody wants to know any special stories about him, I got a lot to tell. So you can see me afterwards. So I arranged this talk into 3 different sections. Before my time in my professional career, during my professional career, and what I think the future holds. And it's about rectal cancer. So we'll get started with the before. There are so many articles about what was the history of rectal cancer and all these different things that go along with it. But I'm only going to talk about a few things. So in 1826, Dr. Lisfranc was the first one to publish operating on rectal cancer. Now remember, no anesthesia, no aseptic technique, and he would tell the patient to bear down, the tumor would prolapse out, he would amputate it, and then sew it up. Now, as you can imagine, there was a lot of bleeding and a lot of infection, a lot of local recurrence. So it wasn't until ether anesthesia, which was a major advancement that was presented at Massachusetts General Hospital, and aseptic technique that we could really advance rectal cancer. And this helped Professor Miles when he was doing his abdominal perineal resection. And I'm just going to focus on him a little bit because there were some very interesting things about him. And the young people in the audience should be thinking about problems the way he thought about them. So in 1908, he talked about abdominal perineal resections. And what he did was he would do autopsies on patients that died of recurrence and figured out that the lymphatic spread around the rectum was where the recurrence was. So he altered his technique. He would operate on 10 to 12 patients. And then when the patients died, he would autopsy them again. And he did this over and over and over. And that was how our technique of rectal cancer was improved. The other thing was way back in the early 1900s, he advocated that women should be accepted into the Royal College of Surgeons, which he was in the minority and they weren't accepted. But as a woman, I was quite impressed with that. I am not going to talk about all the other things that came along, the stapler, 2 people doing the procedure, one from the abdomen, one from the perineum, sewing the rectum and the left colon together. But just to summarize, from 1910 to 1940, most people felt that a permanent colostomy was the procedure of choice for rectal cancer. And after World War II, transfusions really revolutionized surgery because the mortality dropped. But there was still in the 70s a very high recurrence rate in the pelvis. And they were starting to recognize that the recurrence rate was from tumor that was left behind. And that came to the head in the 1980s on total mesorectal excision. And this is Professor Bill Heald. He was in the UK. And in the 1980s, he started to really examine this. Actually, he came to the Cleveland Clinic and worked with Dr. Lavery, which is a little known fact. And Dr. Lavery, I'll talk about in a minute, was one of my mentors. And he came up with this concept of taking out all the mesorectum, which I'll explain in a minute. So you have to realize at this time, local recurrence, so recurrence in the pelvis after taking out a rectal cancer in some institutions was as high as 44%, and that was felt to be okay. He was revolutionary and he published that his local recurrence rate was 0% in his first publication. Now, anything that's 0%, you have to really think askance about, right? But his 5-year results showed that his recurrence rate was 2.7%. And that really revolutionized how we looked at rectal cancer. And I'll talk about him a little bit more in a minute. But his idea, if you look at this picture, was to take out all the fatty tissue around the rectum, which was, when I did my surgery training, was really, my general surgery was really not emphasized. So what was going on with me? So in 1959, I was born. My dad was in Ohio State University College of Veterinary Medicine. He graduated in 1960. We went to this place out in the middle of nowhere. That's my mom and dad and I. And the arrow points to the garage. I don't have a nice picture of it, but the garage was where my dad set up his veterinary practice. And the table on the right, even though it holds my birthday cake, that was where my dad did a surgery in the late afternoon and early evening. And my sister, who's in the middle, and I would sit at one end. That's my cousin. He didn't live at our house. But my sister and I would sit at one end of the table, and he would do a surgery at the other end of the table. And he would hold up organs and say, "Oh, what's this, girls?" And we would say ovary, intestine, things like that. And the stove in the back, my mom would crack the stove open and the dog or the cat would recover in our kitchen until it was awake enough and it could go out, back out into that garage and overnight till the people could pick it up. So eventually in the 1960s, my dad built a proper office. And as you can see, this office was a stone's throw from our house. And we were required before we went to school to go out and help clean dog kennels, do different things. After school, we had to help in the office. We had to help in surgery. So this is what his his clinical room looked like. This is my mom, who eventually got her so did I, veterinary technician degrees. And this was in the office. As you can see, that red arrow is his endotracheal tubes that he intubated animals with. He was revolutionary in our area because most people just gave IV anesthesia, and he had this anesthesia machine, intubated animals, and did surgery. And I didn't realize how important that was at the time. I just would think about, oh, I wanted to be doing stuff with my friends and I would have to assist them in surgery. So I thought, I just didn't realize my advantage. The other thing that was an advantage that really influenced me was my grandma, my mother's mother. So in 1963, she had an abdominal perineal resection for a rectal cancer at our 25-bed hospital in Fremont, Ohio. She was also the city auditor, reelected 5 different times, traveled all over the United States. And I dare you in these pictures to see her colostomy bag. And it really influenced me that a colostomy bag did not define her. So that was another very influential thing in my life with rectal cancer. I went to Ohio State University to medical school. I went to Syracuse, New York to do my surgery training. This is me with my program director, Dr. John Ost. And then I went to the Cleveland Clinic to do my fellowship in colorectal surgery, and then I joined the Cleveland Clinic. So this is now my professional time. So Dr. Victor Fazio was the head of our department, and he was a master surgeon. I learned so much from him. And for the young people in the audience, the one thing that I took away that I want all of you to take away is a good surgeon thinks about what's going on in the present. A great surgeon thinks 10 steps ahead. And he emulated that. And I'll tell you what, I have seen that over and over in people when I've looked at their surgical ability. Dr. Rupert Turnbull was not at the Cleveland Clinic when I was there, but he was revolutionary, and he started our department in 1952. So in 1952, he specialized in colon and rectal surgery. That was really an innovative thought at the time. In the middle is Dr. Ian Lavery. He was the second in command, and he was a master at doing rectal cancer. And as I said, Dr. Heald actually came to the Cleveland Clinic in the 80s to watch Dr. Lavery do surgery. He could do a low anterior resection in about 20 minutes, and the patient opened, and the patients did well. Now, that wouldn't be some chubby patient, but he was really a master, and we all tried to operate like him, but none of us were ever had that technique. And as you can see, this is me, the only woman in the early 1990s at the Cleveland Clinic in this sea of men. Also at the Cleveland Clinic was Dr. James Church, and he was a pioneer in hereditary colorectal cancer and also in young onset colorectal cancer. And I remember in the early 1990s, he said, mark my words, we're going to have an epidemic of people having colorectal cancer in their less than 50 years. And we'll talk about that in a minute. He was really profoundly correct. Dr. Jeffrey Milsom was also at the Cleveland Clinic then. He was a pioneer in laparoscopic surgery. I told somebody yesterday, I never did a laparoscopic gallbladder in my surgery residency. It just wasn't a thing. And when I came to the Cleveland Clinic, Dr. Milsom was doing colorectal laparoscopic surgery. And the other thing that he was doing was ultrasound to look at rectal cancers. And he taught me to do that. And I was in the early 90s and into the 2000s, I was the principal person at the Cleveland Clinic who did transrectal ultrasounds. You can see that when you're looking at that ultrasound, the T3, you can see the little bits of tumor that are outside the rectal wall, and then you could see lymph nodes. And that was the primary way we looked at rectal cancer. However, other people were looking at it from the radiological standpoint, and MRIs were becoming more popular. They had increased ability to see. And this was pioneered by a person named Professor Gina Brown in the UK. And what she did was she really revolutionized how we did MRIs. And it's the standard of care now to do an MRI to look at rectal cancer. We almost never do an ultrasound unless patient has a pacemaker or something like that. But she was really a pioneer, and she really studied it. She came up with looking at the the way the interface of the fat around the rectal wall, and it could really reproduce it, which was really important. She was part of a study called the Mercury study, where they looked at it and they compared the MRI to the specimen that was resected, and she was really a leader. And again, what we're talking about is this taking of all the fat around it, not coning down, which was in my surgery residency, we coned down, and that was why you had a higher recurrence rate. And you're going to come up with this really beautiful specimen with this shiny layer on the outside. How do we grade that shiny layer? Well, Professor Quirk, who was from Leeds in the UK, he was instrumental in looking at this and creating a way the pathologist actually grades us for our technical ability at doing rectal cancer. And he came up with a way of processing the specimen. And then when we take it out now, we're graded by the pathologist. And it really has increased people's awareness how well they're doing rectal cancer surgery. I was lucky enough, because Dr. Fazio was very busy, I was lucky enough to be able to go all over Europe and present our results in operating on rectal cancer at the Cleveland Clinic. And as you can see by what's circled there, the local recurrence rate in the very distal rectum, where the blue is, was quite low. And we had very, very good. We just didn't publicize it as much as some people. So about this time, we're talking about the 1990s, open surgery was the mainstay in colorectal, especially in the pelvis and colorectal cancer. That was because the people that dabbled in the laparoscopic were finding that they might have recurrence at the trocar sites, and it was felt to be unsafe. Dr. Heidi Nelson at the Mayo Clinic, who was, I was lucky enough, she was one of my mentors. She did one of the first in colorectal randomized prospective NIH-supported studies, and it was called the COST study. And she randomized patients to have laparoscopic versus open surgery. And what she found was that there was no difference. It was a non-inferiority study. And she also carried it out 5 years and found there was no difference in the local recurrence rate, in the trocar rate, in implant rate, things like that. And that was a revolutionary study. Also in the early 1990s in Europe, they were trying to figure out how they could teach their people to do good rectal cancer surgery. And Dr. Soryad was very innovative, and you probably have never heard of him, but he was extremely famous at this time. And in Norway, he brought many people, and I was lucky enough because I went for Dr. Fazio twice, from all over the world to come and talk about rectal cancer and how they were going to train the Norwegian surgeons. They were one of the first institutes that really separated rectal cancer surgery and said, only in Norway, certain people are going to do rectal cancer surgery. He brought Dr. Heald in. Dr. Heald did a lot of live demonstrations of surgery, and it was really a first. And we take this for granted now, but it was a first at the time. The Dutch also were interested in this, and Dr. Van de Velde, he was very, he came to Norway and then he went back to the Netherlands, and he took this concept to the Netherlands. And he also was one of them, I'll talk about radiation therapy, that was very instrumental in trying to figure out how we give radiation therapy. And that may sound trite, but you'll see what I mean in a second. So switching gears, in the early 2000s, a rectal cancer, many times we would radiate, sometimes give chemotherapy. When we talk about radiation, we usually give 5-FU with the radiation, but we would sometimes give chemotherapy before. And we noticed that at times the rectal cancer would totally go away, and we would operate and there would be no cancer in the specimen. In Brazil, there was a woman named Dr. Angelita Habergama, and in 2004, she published Not Operating on These People. And I remember very distinctly people from the Cleveland Clinic coming back from meetings where she talked about this and saying, this woman is crazy. And as a woman, I was a little offended by that. But anyway, she stuck to her guns and really followed these patients. She set up protocols where we followed these patients very, very carefully. And her results of doing watch and wait, where after you give the chemoradiation, the cancer totally goes away and has to totally go away and not operating on them. She found that in about 20 to 26% of the patients, you could do that. And there were others in particularly Europe that adopted this practice and verified what she said. And this has become a thing. We've found with improvements in chemotherapy and radiation therapy that about 40% of patients we don't operate on. We watch them very carefully. And if they develop regrowth, we would operate. But in 2004, that was a novel concept. And she was really looked at as a crazy woman, but she's proved them wrong. So what kind of advancements were made from the time we did the biopsy and knew the person had rectal cancer until we did surgery? I can remember sitting in conferences in the early 1990s thinking, why don't we have better chemotherapy for this? This is ridiculous. And actually, the French were the ones that initiated the chemotherapy that's on the right of your screen. And what they did is they gave this chemotherapy as palliative treatment and found patients responded to it. And it just kind of evolved from there to how we were giving chemotherapy as the time went on, the decades went on. And one thing that became apparent was to give all the chemotherapy and the chemoradiotherapy, the radiotherapy with the 5-FU before surgery was beneficial. And why was that? Well, because there was no delay. A lot of times we would do surgery and the patients we would feel needed chemotherapy after surgery or radiation, and they would be too sick or too infirmed, or they had a leak and they would never get their chemotherapy. But giving it before, that solved that problem. The other thing about it was if you had somebody that had a low anterior resection and you radiated that after surgery, their function already was going to have difficulty, was going to be worse. And doing that all before you took out that radiated bowel. And then a third thing is 40% of the patients have no cancer left. So those patients can be watched. The question was, do we give the radiation therapy first and then the chemotherapy, consolidation therapy, or do we give the chemotherapy and then the radiation therapy? And this was answered with a study where they looked at 306 of these distal rectal cancers and randomized them to having one or the other. And what they found at 3 years was there was no difference. But maybe delivering the radiation therapy first, you had a higher chance of having patients that were able to enter a watch and wait protocol. When they looked at 5 and beyond, this held up that the order didn't influence the survival. But again, there was higher rectal preservation, not needing surgery at 5 years. So right now, when a patient comes to see us, what we talk about is, are they interested in watch and wait? And as you know, some patients are not going to be, they want surgery. And those patients, it doesn't matter the order, but if you're thinking that your patient may be a candidate for watch and wait, you would start with the radiation, and probably the radiation continues to work while you're giving the chemotherapy. That's the current thought. So what about the future? So we talked about TME with Bill Heald. This is not the future, but you'll get the gist. We talked about quality of surgery and accurate staging with Phil Quirk. We talked about specialist in imaging with Gina Brown. We talked about improvements in giving chemo and radiation with TNT. But what was missing? What was missing, which I think is really in the last decade come on, is multidisciplinary care. We talk about these patients, we coordinate. There's 5 different groups. There's the surgeon, who is usually the lead, the oncologist, radiation therapy, pathologist. And we talk about all 5 of these people getting together, or 5 groups, and discussing them. And we were not sure we did a lot when we had our multidisciplinary conferences in the beginning. This was a study that we did at the Cleveland Clinic where we looked at, did we change our mind? So we would have our patient, we were going to take it to the MDT, and we filled out what our plan was, and then we filled out what the plan was going to be after the MDT. And we found that over 30% of the time we changed the plan. So what happened after surgery? Same thing. 30% of the time we changed the plan. And that made us really big believers in having the MDT. And we were very askance at first because it takes a lot of time and a lot of effort to organize that. So at the Cleveland Clinic at that time, the chair was Dr. Feza Remzi, and he was really very much not upset, but really pushing for guidelines where all 5 of these pillars in the MDT had guidelines that they had to adhere to give good care. And he organized, I remember very clearly, he gave David Dietz 2 weeks off to go through all the literature. He had no clinical responsibilities and organize these guidelines. And they called it the ostrich, optimizing the surgical treatment of rectal cancer. There were many people involved, and some of you are in the audience, and I'm not recognizing you, but these were the 4 that I remember that were constantly on calls. This was before Zoom, but constantly on phone calls with Remzi and Dietz. This was so profoundly changing for our care of rectal cancer that the American College of Surgeons adopted it as one of its quality programs in 2017. And it's called the National Accreditation for Rectal Cancer, NAPRC. And as of last month, there's 128 accredited programs. So what I really love about this, and I had the privilege of being the chair of this committee from 2019 to last year, and Virginia Schaefer, who is in the audience, she was the education chair to get the message out to everybody. So what this has done to me is lifted everybody's boat, because there's a lot of programs that say, well, we're not NAPRC accredited, but we follow all the guidelines. And I want to say, well, why aren't you NAPRC accredited? But I just smile and say, that's really good, because this has increased the awareness of what's really important in rectal cancer care. And I am proud to say we just completely rewrote the guidelines, and most of the programs are going to not be very happy, because we just tightened them up for a lot of things, because watch and wait wasn't very specific in the original guidelines, things like that. But I just rotated it off, and I'm very proud of the work that we did. So whether you know it or not, we have an epidemic in our country, actually in the world, because I was asked to give this talk in Poland, in Japan, and in China about young onset colorectal cancer. So I don't know how many in the audience saw the Black Panther, but while King T'Challa was doing Wakanda Forever, he was battling colorectal cancer. And he actually was operated on while he was filming the movie and died at age 43 after the 4-year battle. On February 11th, James Vanderbeek died. He was diagnosed in 2023, and he was 48 when he died. And he's not alone. These 2 people are not alone. Early onset colorectal cancer is defined as less than 50 years old. And right now, it's about 10 to 12% of all new colorectal cancers, and it's going up. And I said, Dr. Church in the 90s said, we will have an epidemic of it. And he was profoundly correct. And we don't know why. We don't know, is it the microbiome? Is it the diet? Is there something in the environment? Is it because people are more obese than they were before? We don't know. I think this is really a telling illustration. On the right is rectal cancer in people over 50, and the incidence is going down. On the left, what you can see, the blue line is 20 to 49, whoops, and the red line is less than 50. It is going up exponentially, and it's predicted that by 2030, that's not that far in the future, 1/4 of all rectal cancers will be in people less than 50. I think we need to be telling people that they need, when these young people have rectal bleeding, they need to be doing it digital, because a lot of it is within our digital finger, like it used to be when I was a medical student. These cancers don't behave the same. That's the other issue. When you try to treat them with the protocols that we use for greater than 50 years old, stage for stage, they don't do as well. So we need young people to really think about this. These are biologically different, and we need to stand up and take notice, because this is really, really a problem. This was from Fox News, and my husband sent it to me because he knew I was giving this talk, and this was just in January on Fox News. They did a special on this. So we really, really need people to figure out what is going on here. So the next thing for the future I want to talk about is the miracle in MSI rectal cancer. So as you all probably know, when our DNA replicates, sometimes our cells don't get it right, and we have these little engines that go in and fix it. But in some people, we have mismatch repair. The engines don't go in and fix it correctly. And we call that microsatellite instability. And 5 to 10% of these cancers are microsatellite unstable. So when you do a biopsy for colorectal cancer, the first thing you do is have it tested for MSI. So Susan Galandiak gave this talk in 2019, and this is me with Andrea Sesek before she became famous. And to listen to her talk about how she came up with the idea of a PD-1 blockade in this is really fascinating, and I won't insult her by trying to replicate what she said, but she just had published her New England Journal article, had not been on the Today Show or been famous at this point. And she gave a talk at the Society of Pelvic Surgeons, which is what Dr. Zervos was referring to, about how she came up with this at Memorial Sloan Kettering. It's fascinating. And trying to get a drug company to give her drug to try on these patients, just a fascinating talk. And she gave these patients with MSI instability. Now, this is only a very small percentage, but these cancers usually behave more aggressively. And she found at a year, 100% had no regrowth, completely went away. And as time went on, it wasn't quite as high. But at 5 years, it was in the 90s. And these patients still are doing well. She has gone on to become very famous for this. And this was her on the Today Show in 2025. And she's been lauded as Times 100 Healthcare List of the Year. So to the young people and the early career people in the audience, there's still room to become famous. There's still many things to do. And she is a lovely person and really exemplifies thinking about a problem and looking at it critically and how do we solve it. So one of the last things I want to talk about is controversies in radiation therapy. And you might say, how can there be controversies? Well, still we're not sure. How does it fit in with TNT? Do we give it before or after? Traditionally, we've given long course, which is every day, 5 days a week for a month, and then you wait 2 to 3 months and operate or reassess the tumor. But the Dutch tried short course. They gave it every day for 5 days and then waited. Is it the same? And how long do you reassess? Initially, we reassessed at 1 month, and then it became apparent you could wait 3 months and you didn't affect the local recurrence rate or overall survival. So all these are still up in the air. And these two studies, which are European studies, were supposed to answer this question. But one thing I want to caution you, they took a long time to accrue patients in these studies. They're very different studies, and they're compared frequently in the colorectal literature, but they're not the same study. And they really haven't answered the question. So when you're trying to make sense of this, overall, the survival was no difference when you give the radiation. Local control was no difference. There's a lot of problems with the methodology because these studies took a long time to accrue patients, which is not unusual when you're doing surgical research. Maybe giving additional chemotherapy after you do surgery is good. Memorial Sloan Kettering is not even given the radiation therapy. They're just giving the chemotherapy right now, and they have a study called the Prospect Study where they're looking at not giving any radiation. So how does the radiation even fit in? I don't have an answer, but these are things that the young people in the audience, I hope, grasp onto and can answer. So in conclusion, we've progressed a long way since Miles figuring out lymphatic resection was, the way to go for APR to reduce the local recurrence rate. Now we provide individualized care through the multidisciplinary conference and team, and the team members really are all important. The first thing to do is biopsy. If it's microsatellite unstable, we're going to give some type of a PD-1 type blockade. Then if it is, stable, we'll give TNT and reassess. Watch and wait is a thing. Right now, 40% of patients with rectal cancer are put into a watch and wait program after they have full TNT. The problem is diagnosing regrowth. And I I've heard, so after I've retired and I'm traveling around at horse competitions, I'll have people come up to me at these competitions and tell me about their TNT and tell me about what their MRI shows. And I'm like, oh my God, they have regrowth. And I say, you got to go tell your surgeon that Tracy Hall said you need an operation. And I've had that happen 3 times in the last 6 months. So we can't put our head in the sand like ostriches. We have to operate on these people when it's appropriate. There is a lot of things in this miracle of progress of rectal cancer that we have overcome, but there's a lot we still don't know. And I, again, encourage the young people in the audience to be curious about it and to go forward and solve these problems. So thank you very much for the privilege of giving this talk.
Tracy, thank you so much. I think that's exactly what we wanted, and that's exactly what we needed. And at this point, I want to present you with this little remembrance. I want you to go home and put this on the shelf right next to the endotracheal tubes that your dad had. And because I know you're still living in that house. And this is in recognition of your delivery of the Arthur Hamblin Letton Lecture, awarded to you for your talk at the Southeastern Surgical Congress 2026. All right, I'm looking around for people to tell me what to do, and I don't see any of them, but we're a little bit ahead of schedule, so we're doing good. So we're going to charge on. Eddie's coming up. Yeah, Eddie's going to co-moderate the